Hi, Courtney. We have a panelist that is under the attendee section. Pranitha, how do we fix this?
Let me move her over. I should be made host. Can you please make me host so that I can move over the attendees? This is Courtney. Can you please make Courtney host? FPD.
Hi Diane, you're speaking to Ndlandla. I will share the screen with you for the polling questions soon. We're just having a little technical issue that we're just currently sorting out on our side.
Hey, Grace, thank you so much. Courtney is trying to move someone over, one of our panelists over.
Okay.
Courtney.
Okay, Courtney. So I'm just updating you regarding the polling questions. I'm just quickly updating it on our side because we just have a technical issue for me to share the polling questions with you.
Okay, thank you.
Because I was advised that you. Okay, thank you. Bye.
Hi,
Great. I'm glad you're on.
thank you.
Okay, I think we're just waiting for the slides to come back on. Thanks everyone for your patience. We'll begin momentarily.
Hi there, FPD. Could you please pull up the slides for this show?
Okay, Courtney, does that mean you're going to move the slides? You can see your screen. Okay, we're ready. Okay. Great. Okay. Hi, everyone. Sorry for the brief delay. We were sorting through some technical difficulties. My name is Diana Frimas. I am the Health Workforce Branch Chief in OHA in USAID Washington. Thank you for joining our session today on priorities for optimized staff investments. This is just a quick recap of our overview. I'm going to give a brief overview of our USAID HRH staffing priorities. And then I'm joined by Jennifer Daniels, who is the HRH specialist at USAID South Africa, who's going to talk about the South Africa experience with tracking and using HRH data. And then we have several partners joining us to give some perspectives from the South African context. Dr. Papi Mujaba from Right to Care, Dr. Nado from Match, and Dr. Martin from VITS RHI. Next slide. So staffing is a cost driver of PEPFAR programs and representing over 22% of USAID global expenditures, and noting that this is likely an underestimate as it excludes related expenditures by subrecipients, which do represent a sizable proportion of USAID partner expenditures. And this highlights the need to have a better understanding of HRH and other staff supporting programs through robust tracking and use of data to ensure optimized staffing for performance. Next slide. So over the past several years, there has been increased inquiry from OGAC on health workforce and other IP staffing investments, including of staff who not only provide service delivery, but also those who support non-service delivery activities and support program management functions. And the types of questions that we've been getting include, what is the entire footprint of staff and associated expense? What is the staffing composition by cadre and distribution of staff across SNUs and PSNUs and at the facility level? How does staffing across the PSNUs align to program targets and target achievement? What staffing level is really needed to support target achievements? And then of course, over the past 6 months with the COVID-19 pandemic, how is COVID-19 impacting staffing? Next slide. And just a brief example of how we expect to use data to answer some of these questions. This is just an example of the type of HRH data use that we're looking to advance. This example depicts % total facility and community staff full-time equivalent alignment to share of TX curve targets by PSNU. One may expect to see alignment of % FTE to TX curve. And this type of analysis can be utilized to inform dialogue about staffing alignment and needs, coupled with HRH contextual information aligned to the context across each of the PSNUs. Next slide. Just to do a quick overview of the status of PEPFAR HRH data sources. So for MER in Q4, which we just, Q4 reporting of course just started, there is HRH CUR and HRH staff NAT. HRH CUR is meant to capture the number of healthcare workers who are working on HIV-related activities and are receiving any type of support from PEPFAR, as well as the total spend. The limitation here is that it only captures staff who are providing HIV services to HIV clients, not technical assistance or program management. And it also lumps many distinct cadres into broad categories, which limits our analysis to understand the linkage to performance. In expenditure reporting, all staffing expenditures are captured across various staffing categories, but it doesn't capture the number of staff or the number of costs by each of the cost categories, nor does it disaggregate the staffing expenditures, again, under the subrecipients. And then lastly, as a result of these limitations, several countries, and many of you may have participated in these exercises of conducting HRH inventories that are meant to capture the entirety of the IP staffing footprint. Unfortunately, though, these are not yet standardized. They've been very ad hoc, but we do know that they will be replaced. If you noted in the MER guidance that has just been released, they will be replaced with HRH CUR in FY21 Q4. Next slide. So recognizing the importance of HRH and other staffing investments in achieving these results, USAID has really been working to, again, advance a data-driven HRH response, not only for greater accountability, but also impact on client-centered care. And in COP20, work planning just noting the increased focus that we had on ensuring that work plans incorporated more of a focused description and detail on your plan staffing investments, the methods for determining those staff needs and allocation, and also the methods for how to monitor those staff performance, particularly for staff who are providing services to beneficiaries. Next slide. And then having a standardized and consistent data source across countries, of course, has been a big key constraint for us to advance this agenda. And while we await this new HRH inventory requirement in FY21, here are just a few recommendations based on our experience working with different implementing partners on HRH tracking for how you can strengthen your own internal tracking to guide HRH and staff reporting use, data use for decision making. You can organize your staffing tracking by the respective ER staff categories and align key data elements, including things like role or cadre type of the individuals that are being supported, alignment with associated data hierarchy of location, the level of effort of that individual, primary program areas supported, staff employer, whether or not they're employed by the prime or the subrecipient, and then annual remuneration and compensation type. Next slide. Lastly, before I hand over to Jennifer, I think recognizing that over the past 6 months, you all have been working tirelessly to adapt and reconfigure your staffing to support safe delivery of HIV service during COVID. Including recognizing overcoming HRH challenges that have already been there that have been further exacerbated, right, by COVID. And a lot of these were highlighted in Q3 reports. just to note, moving forward, I think it highlighted the need to anticipate continued staffing needs and shifts and supplies such as PPE as services resume in order to prevent any further delays and address any concerns or fears for worker safety. The importance of continuing to monitor how you are adapting staffing and those shifts to enable a rapid response. And also how to consider how to maintain some of these staffing shifts and delivery models while we continue to operate in a prolonged COVID environment. Lastly, several countries have indicated that COVID-19 is already affecting resource availability for HRH wages and risk allowances and hiring of government staff. And this also highlights the need for increased focus on having more optimized use of HRH staffing by USAID partners and host country governments, and really where we can identify more efficiencies and ease those resource gaps, and to really understand, and I think having your understanding of this and relaying it to USAID as well, of what you're seeing on the ground as being anticipated HRH financing requirements. And with that, I'm going to hand over to Jennifer, who's going to talk about the South Africa experience. Thank you.
Good afternoon, colleagues and partners. Thank you, Diana, and to the OA team for the opportunity to share how South Africa has been strengthening the use of health workforce data, but more importantly, how the HRH data enabled all our implementing partners to for rapid staffing adaptation and innovation during the COVID pandemic. You can go to the next slide. Yes, so I'm starting off the presentation that shows that there's still a lot of work to be done to achieve the 90-90-90, or rather the 95-95-95, with progress towards a second 90 being the lowest at 73%. Next slide. Thank you. Now I will provide an overview of how the South Africa program focused its investments on frontline healthcare workers as a key strategy to accelerating the HIV gains in the country. Staff levels escalated from Q1 of COP19 in line with the goal of the 2-year HRH surge, which have been extended up to the end of March next year. So essentially what it means is that implementing partners or district support partners will maintain similar staffing levels from Q3 of COP19, which, as you can see, was at 8,527 until the first 6 months of COP20. Next slide. This slide is showing the investments in workforce, particularly frontline healthcare workers providing direct service delivery to beneficiaries, which was one of the core interventions starting from COP19 to COP20. And really the objective of placing supplemental staff at the high volume health facilities was to increase the facility's capacity to maximize HIV case finding, treatment initiation, retention, and adherence at prioritized high burden facilities. And also the context of the additional service requirements resulted from the increased patient volumes from the National Wellness Campaign and the SEARCH plan, as well as the scale up of the CHW and the CCMMDD programs. Next slide. Just checking my. Yes, so this slide, sorry about that. This slide is looking at partner contributions versus the DOH contributions. And it was really at the start of SEARCH where we started collecting the reporting requirements through our DSPs. And at the Cienza sites, which is typically our high volume sites, in Q4 of COP18, the DSP's HRH workforce were responsible for identifying 60% of the HTS POS at the time, and also contributed to initiating 68% of the TX new target. Next slide. Thank you. This slide is showing the growth in the number of site-level healthcare workers by cadre. As of August 2020, USAID SA frontline workers providing direct service deliveries to beneficiaries represented 83% of the total staffing footprint. And what we have seen is that among the implementing partners, the top 5 cadres placed by IPs to support their HIV and TB programs include professional nurses, case managers, linkage officers, field tracers, lay counselors, as well as data capturers. Next slide. Thank you. This slide is showing the importance or the routine reporting by all PEPFAR supported partners. And USAID South Africa requires that all funded implementing partners to capture their workforce on this inventory, what we call the Human Resources Inventory Database, HRID. And the purpose of this inventory is for the USAID South Africa partners, or for USAID South Africa, sorry, to obtain detailed, accurate and real-time data on all South Africa-based staff funded by the IPs, improve our understanding of the extent and nature of USAID's South Africa's human resource investments, and also to facilitate PEPFAR South Africa's strategic planning towards transition of key positions to the South African government or other institutions, depending on the transition pathways, and then also to improve our understanding of where PEPFAR funded positions are providing service delivery. And also through this database, it also assists partners and their AORs to observe any staffing shifts and trends and be able to triangulate it with their quarterly program performance. Next slide, thank you. This slide is showing how USAID South Africa have been coaching all IPs to improve their HRH tracking and use of data for decision making. So facility level staffing inventory is utilized for more robust program performance monitoring, program planning, staff placement, and MER reporting. Program management at the IP level have regular data review meetings with the USAID team, which they use to reallocate staff on a weekly basis according to the need and the gaps that they would observe when looking through key performance indicators like your TX-SCR, HTS POS, and TX-NEW. Also joint planning between USAID and the implementing partners, really looking at the performance indicators to identify sites for targeted site supervision and support, and then also weekly tracking of performance and productivity of key cadres. I will show an example later in the slide from one implementing partner, how they are tracking the performance standards by cadre. And then also some implementing partners also have a reward and a recognition system in place based on the performance standards being met by their staff. Thank you. Next slide. Yes, this is the example from METS, really how they are tracking how their team who's providing direct service delivery to beneficiaries, they're able to update on the Android app how many services how many clients, sorry, they've seen against their performance standards for either on a daily and on a weekly basis. Next slide. And now I just want to quickly spend a bit more time talking about South Africa's COVID response and where we are with that. So South Africa is currently emerging from a significant COVID-19 peak that took place in July and August of this year. And of more than 670,000 infections, approximately 49,000 are still active cases. The testing positivity rate has dropped from 27% to 9% since July. And then we are hopeful that this positive trend will continue. And then early antibody sampling suggests that far more asymptomatic infections may have taken place in South Africa, leading to the decline in new infections now. Evidence remains inconclusive and requires further study. Next slide. This slide, still, South Africa remains the epicenter of the COVID-19 on the continent, constituting half of the continent's infections and death rates. We know that COVID-19 related deaths are likely underreported, with some 30,000 excess deaths reported. And also to mention perhaps the biggest concern moving forward is the reduction in testing and distribution of the testing kits. COVID-19 testing now requires GP referral, and a full 56% of testing has been done in the private sector facilities, where only 20% of South Africans receive their care, and the testing in the public sector is underrepresented. Next slide, thank you. And linked to what I've just shared on in terms of the COVID picture in the country is really the timing when the national lockdown started. There was a significant drop in the facility attendance when lockdown level 5 was implemented from March 27th through to May 1st. And facility attendance remained low even when the lockdown was moved to level 4, significantly impacting our patients honoring their appointments. And then in July, 23% of facilities had closures for 1 day or more due to COVID-19. As you can see on the graph on the right, that shows the number of and percentage of facilities with closures for more than 1 day due to COVID. And it is really in these instances where we have observed that our IPs acted swiftly to reallocate their staff to other facilities. And then also the bigger graph, it shows the total patient head count, and the pediatric cases shows a 27% loss in the total patient head count, in a 41% loss in the pediatric patients during the month of April. Next slide. This slide is showing the HTS POS and TX new dropped from the first day of the lockdown. Proxy linkage remained at more than 95%, and proxy retention was at 95%. And during this time, what we have observed is the IP's ability to initiate new patients significantly dropped during this time. Next slide. Yes, so on this slide, I'm sharing a few examples of how our implementing partners have used their data to inform staffing needs and reconfigurations to minimize service disruptions during COVID-19. And then what we have seen is that the increased missed appointments really elicited innovation by partners to start with the home art delivery. And some partners have also done that in partnership with Uber. And that was really the data sources to that really elicited that innovation was by partners observing the decreased headcount at facility on the number of patients with missed appointments. And also what partners have done was to integrate the HIV and TB services during the COVID household screening that took place earlier this year. And then also our workforce, supported by the implementing partners, have supported the National Department of the Health's activity on the COVID no-touch home screening. And also what we have seen, how partners have responded to COVID and really trying to minimize service disruptions, was to scale up of the external pickup points for art collection. And our field tracers, trackers, they have shifted to conduct telephonic tracing through the file cleanup. The data on facility closures used to determine those ongoing and rapid staffing allocation to other sites where the sites would have been closed due to COVID. Lay councillors have also implemented or disseminated more broadly the HIV self-screening kits. And then also importantly, and we'll see more on this, is the decentralized approach to service delivery that majority of our partners have taken to ensure continuity of service delivery to their beneficiaries. And then what we've also seen is that partners are deploying multidisciplinary teams deployed at community level. Next slide. Yes, so this is the percentage of total staff not at work trend in the metros, City of Johannesburg, Cape Town and eThekwini. And between May and July, we saw a higher percentage of both clinical and data staff affected by COVID related absenteeism in South African metros. And the first arrow that you see there, it points to the start of the SA lockdown. And then the second arrow shows the peak in the number of active cases that we have seen in the country. Next slide. So linked to partners seeing that a majority of the staff affected by COVID is the data staff and clinical staff, partners have implemented targeted interventions aimed at prioritizing staff safety. Some of the IPs, they have procured mobile data capturing units, as seen in the picture, to be used as additional spaces for back capturing of the data and for the safety of their staff. Next slide, thank you. So this slide is a case study by one of our district support partners, MEDS, and which describe how the organization have made staffing modifications by risk profiling all of their staff. Dr. Naidu from MEDS is one of our panelists, and Dr. Naidu will speak more about this during the panel discussion in a bit. So MEDS conducted the virtual risk profiling of all staff aligned to the clinical guidance for COVID. And then based on the risk profiling outcomes of each of the staff, they were able to task shift their staff who are more at risk, the categorization of high risk staff, those who are above 65 years of age, and really tasks of them to working from home, teleworking, so that they are still productive, but also keeping their safety as one of the highest priorities. Next slide. Yes, and this also continues to say that clinicians assessed, those clinicians who were assessed as high risk conducted activities that promoted social distancing, and then the program managers, supervisors at high risk, they worked remotely and continue to provide program management support, conduct meetings, and support site level supervisory visit through the virtual platforms available. Next slide. Thank you. So a key priority of our implementing partners was to move services outside of the facility to community level, and amongst those activities or how they have modified service delivery was really to see how best and how fast or efficient they are able to decant stable patients outside from the facility, also increased the external pickup points, continued with the home art delivery, as I said, in response to the significant drops that partners have observed in their facility head count. And then you'll see there the facility services did continue, but at lower levels due to the increased COVID rates and the high number of facility closures. And the back to care services at facility level included the Welcome Back campaign, intensified track and trace efforts through the telephonic phone calls, and then linkage officers, navigators also assisted in the back to care efforts. Case management activities included the SMS and phone call reminders. And then lastly, we've also seen how partners successfully was able, in terms of the virtual tracking and TA support activities that partners have done, included the tracking and tracing through the file cleanup and the telephonic tracing of patients that they have reverted to ensure continuity of services to both the sites and to their beneficiaries. Next slide. Yes, so partners have really leveraged staffing and service delivery modifications that were made pre-COVID, which included the existing pickup points. And the focus during COVID was to increase the number of the external pickup points for clients to still be able to access their medication outside of the facilities. So this graph shows facility-based medication collection models being reduced at the fast lanes from 867 to 264, and meds collection at the adherence clubs at 248. And then also what was very exciting to see how partners have scaled up the number of external pickup points, which increased from 1,427 at the end of March to over 2,100 at the end of June. Next slide. This slide shows how USAID initiated supportive technical assistance calls to sites while COVID rates increased. I'm just going to quote one, read out one quote from the implementing partner, saying that we have learned about ways to improve the service, start to think about initiatives, ideas on improving the areas that are not performing well at the beginning. Next slide. Yes, so this slide is showing how the some of the frontline workers were task shifted to a telework approach due to their risk profiling, and 8 clinicians over the age of 60 in KZN, called the Elite 8. They were assigned to work from home due to the high COVID-19 risk factors. And these nurse clinicians switched over or almost 5,000 patients to TLD in just 3 months. And now I will, next slide. That's yes, I will now hand it back to Diana to open the panel discussion, during which we will learn from our panelists from the 3 organizations to share their perspectives and lessons learned for HRH during the COVID pandemic. Thank you.
Thanks, Jennifer. And we actually have a couple of questions from your presentation. Thanks so much for the excellent presentation. I just want to pause here first so we can cover those questions. So the first question that we got, if you can respond to, is how did the increase of additional staff affect your approved budget, and did you get additional funding?
Yeah, hello.
Sorry, this is for Jennifer.
Oh, okay.
Jennifer,
I'm just reading the comment, the question. How did the increase of additional staff affect your approved budget? Yes, so that was a specific request that we had to make to OGAG, and also in response to civil society's request for partners to extend their search level staffing at least until the first 2 quarters of COP20. So that was a specific request that we had to make to OGAG to get the additional funding, which was ultimately approved.
Great, and related to that, was there a target set for the HRH surge based on targets, PLHIV? Can you talk a little bit about that?
Yes, so the main goal of the 2-year search was really it had a very ambitious goal, working with the Department of the National Department of Health or South African government to say as PEPFAR or as the USAID implementing partners, they will place up to 8,000 supplemental staff to in line with our target to place an additional 2 million people on living with HIV on ART. So that was really the target and that we're still aiming to achieve. Thanks.
Great, thanks, Jennifer. And one last question from Callie about any leverage or utilization of the PEPFAR supported HRH as it relates to the COVID response. And can you talk a little bit about that? I know you didn't focus much discussion on how you responded to COVID services.
Sorry, and I'm not seeing the question.
It's from Callie. Has there been any task shifting of healthcare workers from HIV to COVID during the last 6 months?
Yes, definitely. So when we were at the start of the really confronted with the COVID surge or during the lockdown in March, as the USA team with the IPs, we have supported the government with the no-touch COVID screening, where the community healthcare workers, they were the primary cadre that participated in that initiative. But then later, other staff cadres like your lay counselors, case managers, they also participated in those household visits. Not only to support COVID, but also to integrate HIV and TB services during those household visits. I hope that answers.
Okay, great. Thank you so much. And so as a reminder, if folks have more questions, please add them into the chat box. Now we're going to transition over to some perspectives from several of the South African partners joining us from Right to Care, Match, and again, BITS RHI. So next slide, Courtney. The first question for Dr. Poppy and Dr. Pranitha, can you share lessons learned for HRH and COVID and how you will continue to adapt to COVID long-term? We've heard a lot from Jennifer, but please add in any of your additional experiences or perspectives or recommendations.
Hi, good afternoon all. This is Dr. Pranitha Naidu. I'm a technical lead from Match and happy to be on this panel. I think from Match side, from the very outset of the COVID pandemic, we positioned ourselves to be able to support our staff and to support at facility level. And I think the one thing that really supported us in being able to adapt and also to be able to align our staff to the facility needs was having done a risk screening and risk profiling from the very outset. We had adapted this model to do an online screening for our staff. This was done daily or as on a needs basis. And also at facility level, there was a risk screening done. As Jennifer had mentioned, we also did a risk profiling. So from the risk screening of staff at facility level, we were able to then assess what the needs were at a facility level and then allocate staff accordingly based on this. So we also received from our staff via supervisors our daily staffing at facility level, and were able to identify the gaps, particularly when staff needed to go into isolation or into quarantine. And from this assessment, we were able to note that we saw that there was greater risk of infection from our staff that were data capturers and filing clerks. And I think this is particularly because for the way some of the facilities are structured, these are staff that tend to come into contact with almost all of the clients that are accessing art services. As part of our support to these high-risk staff, we provided sneeze screens wherever possible. We also ensured that they had the necessary PPE, not just masks. We noted that the filing clerks and data capturers did benefit from also receiving visors, disposable aprons. There was a request for gloves, but based on the guidance from WHO, we felt that gloves would not be suitable for these staff. They were still at risk. So we also ensured that they had hand sanitizers available to them on an ongoing basis. Our provision of PPE to our staff has been on a continued basis. We've actually looked at what their needs are and then provided top-ups whenever needed. With regards to the data captures also, we adopted a roving model for staff for data captures, especially if these facilities had high numbers of staff that were going into isolation or quarantine. For the data capturing teams, we also put in place any need for overtime, after hours work, and especially at our high volume sites as we would categorize them. So really just looking at using our risk screening and our daily reporting to feed back onto how we allocate staff, especially if a facility was closed, then allocating those staff to additional facilities. And I think as Jennifer had mentioned in her presentation also, from the program management and supervision piece, we continue to do this in earnest. We used whatever virtual platforms were available to us to be able to do this and move forward with actually supporting our staff at site level. I'm going to hand over to Poppy and then I can come back to the adaptations. Thank you.
Great, thanks so much. And just if you all are able to use your video, that would be great.
People elsewhere. My name is Papi Majuba. I'm the Chief of Party of the APACE program at Right to Care. Yeah, indeed, I think we did experience the effects of COVID on our workforce. And I think in our case, I mean, we estimated that around 25% of our implementing staff at some stage were affected, either being testing positive or having to isolate due to exposure to COVID. So that necessitated us to ensure that we put in place, I think, structures that will try and mitigate the effects of the pandemic. We had in place staff representatives from all the areas and line managers that put time aside to manage the COVID, especially in the workplace. We organized testing for those employees and ensured that there was enough and consistent screening and contact tracing, and ensuring that SOPs are in place for infection prevention and control, and monitoring that the staff who were coming to work were adhering to these. We also supported logistics on how to, for those who couldn't even isolate in their homes, and make sure that they can get isolation or quarantine facilities elsewhere. And we also ensured that we categorized also our teams and looked at teams, those who were working in offices and those who were working in the field. Those who were working in offices where we found out they could still work from home, we made it possible for them to use their trade, the work trade measures to ensure that they can still continue working from home. But for the teams in the field, we ensured that they are provided with necessary PPEs, and they were really training. Training was the key issue, because I think a lot of people felt that they were not at high risk, especially the data teams as well as others who were not patient-facing. And we also ensured that all our offices and areas of work, we had, we channeled the flow in terms of single entry into offices and to ensure enforcement of screening and other IPC measures. I think of key importance was the issue of ensuring that there's regular mental health staff engagement, because I think for those who were affected, we felt that they needed more support for them to be reintegrated once their period of isolation ended. As I said before, we used a lot of collaboration platforms for staff engagement and training. And the screening of staff and categorizing them as high, medium, or low risk was done early in the epidemic, and ensure that roles were reviewed or changed for those staff that were found to be high or medium risk. For example, in one of our districts, several of our medium to high risk clinical staff were transferred from facility-based clinical work, and they were transferred to the district COVID center, where at least the working environment was allowing distancing, social distancing, and observance of infection prevention control. There was also, I think, a big look and shift in terms of shifting the roles of staff where programs could not continue if they were high risk. For example, staff were shifted around and used mobile services where possible, where staff were not maximally available in areas. We deactivated any physical and closed off all the biometric log-in devices for our staff, and shifted to manual timesheet to minimize staff using the same biometric log-in device. We ensure that we establish clinical committees to monitor and follow staff that test positive. So each staff member who will have been positive and isolated or staying at home, we will ensure that they are contacted regularly and make sure that they get the support that they need. Obviously, the installation of automatic hand sanitizers in all stations and communal touch points were re-emphasized. Well, one area where we found that staff were really infecting, there was a clusters of infections were in communal setting areas, where in kitchens or canteens during lunch times and any breaks. We closed those and ensure that staff don't go into those areas, and to ensure that we don't prolong the infective clusters there. And also we implemented a phased working back to work measures for those who were working at home that were ready to come back, with modifications on how they could be less exposed when they come back. And then we ensure that there's some flexibility in how staff were working from their workstations as much as possible, where there was enough alternative space and the like from the facilities where they were working, as well as in offices. I think those were some of the things that we learned and tried to implement during our during the peak of the pandemic.
Great, thank you so much. In interest of time, Courtney, I'm going to ask you to jump to one more slide. Great. Dr. Martin, can you talk a bit about how you've used HRH data to respond to COVID? So we've heard a lot about those different adaptations and kind of different interventions. Can you talk a little bit more about the actual use of data during this past 6 months?
Good afternoon, Diana, Jennifer, and colleagues, and thank you for the opportunity. Yeah, so in terms of our HRH data, definitely being able to quantify use that data allowed us to quantify the extent and the impact of COVID amongst our staff. So this allowed us to see where geographically which areas were more affected at different points in the epidemic, as well as which cadres were impacted the most. I think, as my colleagues have mentioned, the data on the cadres became very critical as to where the impact was felt, and then we were able to take that and to ensure that we implemented specific interventions for those cadres that were more directly affected. I think they've mentioned the data capturers, and so having that data and information available around which cadres were affected allowed us to be very specific in the infection prevention control interventions there, as well as ensuring that we provided specific messaging and interventions to protect and mitigate the risks for that cadre. I think the HRH data also enabled us to better quantify the impact on the program activity. So where we saw declines in performance in particular facilities, and we could match that to our HRH data as to where we'd had staff who'd been in quarantine or isolation, and so this also allowed us to then adjust the daily, weekly, and monthly targets to towards our program performance. And I think that this is also going to be critical now as we implementing our catch-up plans, and to understand where the gaps were, and which cadres we need to have available perhaps for extended hours and weekend services, and in terms of planning what may be required and to what extent to implement these catch-up plans. I think Pranitha has also talked about the detailed data available around the comorbidities, which we also used so that we could protect those at highest risk for COVID.
Great, and I'm gonna give you one of the questions we've gotten from the audience, the attendees. And maybe if you could just give your perspectives and experience on how easy has it been to do, weekly data review and look how to reallocate staff even on a weekly basis, and how has this affected staff performance in your perspective from being shifted to various activities?
Yeah, I mean, I think the programs in South Africa are very data driven. And so certainly even prior to COVID, we were doing weekly data reviews of our performance data, and using that on a weekly basis to reallocate staff. So that system is already built into our internal monitoring systems. The data comes through on a weekly basis. It's analyzed. We meet as a team to look at that data and have a discussion, kind of flagging facilities where there are issues, and the site leads for those facilities then have an opportunity to explain the context, and as a group we can then determine what is needed. I think Jennifer alluded to this, but also that being very flexible around that shift between community and facility became really important at this time. And so if we knew a facility was closed, what could the community team do, and how could we bring them into that area to compensate for that. And so certainly the weekly review of data is something that is part and parcel of how we implement our programs. In terms of affecting staff performance, I think on the most part, I think everyone was very resilient during the COVID period, and I think willing to go an extra length to do what needed to be done. I think for the most part, we were shifting cadres, so for example, from facility to community, and so they were still able to perform their activities in that way. Yeah.
Great, thanks so much. I'm going to ask you to stay on. And Courtney, if we can move to the last question. Great, so I'm just going to open this up to all of our partner panelists, and also to Jennifer, if there's any other innovations or insights that you would like to share. We have a couple more minutes left before we conclude.
Hi, this is Pranitha. I'm happy to go ahead. I think from our side, particularly for patients that were not keen to come into facilities and were at risk of missing their visits, we had contacted them telephonically and offered them home deliveries. So we supported this via Uber, but also via the Match community teams. And we were also grateful to have support from the VMMC partners that had offered their support as they had scaled down on their VMMC activities due to the COVID restrictions. So I think that this really worked for us. But also we found that collaborating with academic institutions during this time to support training at facility level, both for TB IPC and COVID IPC, really then put people at the forefront of having the latest and most and available information to them to be able to support COVID IPC and support facility readiness. I think also we were able to also adapt our prep services in such a way that to the COVID restrictions and still ensure that we reached our target. So really reaching out to the teams to go out into communities, ensuring that there's all the restrictions maintained and ensuring that they were safe, but also providing this care at facility level, especially for home deliveries and taking medication out into the community. Thank you.
Great, thanks so much. Anyone else?
I think the other point to put up is that it gave us an opportunity to change our focus in ensuring that there's increased demand for smart lockers, CCMDD, and home deliveries, as they've said before, to assist decongest the facilities. And this also allowed us to refine the efficiencies of using our staff effectively to ensure that at the same time decongesting facilities and making alternative pickup points for patients. It also allowed us to use our staff effectively without, congesting them in facilities where they will be at risk of increased infections. So it also gave us a more I think sensitivity to ensure that all the risk factors that will allow better and continued delivery of services. In other words, it made us to be risk averse for all matters that will allow for uninterrupted business continuity, in the sense that we looked at all the risks other than the risk of infection, how we utilized our communication structures, as well as ensuring that our protocols and modifications on movement between staff themselves, between clinical and non-clinical staff, create a better and also efficient working zones where it will have been difficult to allow them to work without, and understanding where they should work without coming into contact with those they will have exposed to infection. So I think the business continuity, risk averse, as well as looking at the whole implementation of programs in totality was one of the lessons that I think this pandemic has helped us to refine.
Thanks so much. Catherine, any last thoughts?
Yeah, I think for us as well, the use of the virtual platforms, we touched on it briefly, but has also been something that I think we would take into our program long term. I think, we manage some quite remote areas, and sometimes it's not very cost effective to bring people together, and all the travel costs entailed with kind of big group trainings. And so I think there are definitely some lessons learned from these virtual platforms that could be taken into our future programming as well. And I think that, as I mentioned before, having good systems in place in terms of your data collection, even the HRH data, having those systems in place, I think, allows you to be very responsive and flexible then when a crisis like COVID hits. And so I think it is worth continuing, to invest in those systems and make sure that, that those things are strengthened where possible, so that you can then be as flexible and responsive as you can be when these crises hit.
Great, thank you. And I think that the South Africa experience definitely highlights how you already were using HRH data and had strong systems in place, and it was you were able to rapidly kind of use that to respond. So I want to thank everyone who joined us and your perspectives and sharing the hard work, especially over the past 6 months, in addition to your broader HRH use of data and systems. And Jennifer, thank you so much. We are over time. My understanding is that the presentation will be made available on the ASAP site after the conference. And then lastly, I'm supposed to announce the 3-question Zoom poll as part of the wrap up. And I think that will pop up. I see people are leaving, but if you want to stay to take the poll, it should pop up any second. Okay, well, thank you again, everyone. Have a good rest of the day. Thanks again.
Thank you. Goodbye.
Thank you.